Dr. Ladle mentioned earlier on work about STING agonists, so it's a great honor to welcome Dr. Erin Resch from Johns Hopkins. And she's going to talk about antecedent STING agonist therapy improves tumor response to chemotherapy in murine models of osteosarcoma. Please welcome Dr. Resch.
Making sure I can work the clicker. Good afternoon, everyone. My name is Erin Resch. I'm a postdoctoral fellow and clinical fellow in the pediatric oncology program at Johns Hopkins, and I've been in Dr. Brian Ladle's lab for 4 years now, and I'm going to talk today about some of the work that we've been doing trying to use immunotherapy to enhance chemotherapy in mouse models of osteosarcoma. Before I start, I just want to thank CCF for the invitation to talk today. It's been a really wonderful day, and I just want to give a special thanks to Kate and Nicholas and their families for talking today. For me, it's really been a highlight to hear some of the patient stories, so thank you for sharing your experiences. So osteosarcoma, as most people in this room know, is the most common malignant bone tumor in children. I like to show this graph over here just to show sort of the advancements that chemotherapy made for the treatment of osteosarcoma. Prior to the 1960s, overall survival was around 10 to 20%, as our only treatment option was really surgical resection. But with the introduction of multi-agent chemotherapy, we were able to make significant improvements in overall survival for our patients. And that led today to our standard of care upfront chemotherapy regimen for osteosarcoma, which is MAP chemotherapy. So we give neoadjuvant and adjuvant cycles of chemotherapy around surgical resection. And with that, we've been able to achieve an overall survival that approaches 70%. And as Dr. Ladle alluded to before, that's pretty good. It's a pretty good number, but we think we can do better. In our lab, we don't necessarily think osteosarcoma or sarcomas in general are going to be able to get away from using chemotherapy. But what we want to try to do is to use immunotherapy to enhance the response and treatment response that we are able to achieve with MAP chemotherapy. So I'm going to talk about a lot of themes in osteosarcoma that we've heard in other tumor types today. So specifically with Dr. Cronk's talk about glioblastoma, we see a lot of similar immune challenges in osteosarcoma. So this, for those of you that are not familiar with IHC slides, this is just a picture of what a dog osteosarcoma tumor looks like under the microscope. So all of the bluish purple cells are mostly tumor cells, and the pink is the osteoids, so like the bony matrix that these abnormal tumor cells are able to make. This is just what osteosarcoma looks like under the microscope. If we take that same tissue section and we stain it for different markers of different immune cells, we're able to see these positive brown cells and look at the infiltration of these tumors with different immune types. And so here we're looking at CD3, which is a marker for T cells. And what I want you to take away from this is that for the most part, we're just seeing these blue cells with very, very few brown cells, so very few T cells that are able to infiltrate these tumors. And the T cells are really what we need to be in these tumors to do the work of getting rid of them. What we do see are a lot of myeloid cells. So these brown cells here are looking at innate immune cells. Most of these cells are suppressive in the environment, so they're keeping out some of the effective immune cells, effective T cells from this coming into this tumor. And our goal is to try and get rid of these cells so that we can improve T cells coming into the tumor. And so, as I said, what our hope is that, this is just a diagram of what the tumor looks like, and we see these immunosuppressive macrophages that are within the microenvironment. Is there a way that we can use immunotherapy in combination with MAP chemotherapy to create a hot microenvironment that has a lot of activated immune cells that are able to help with clearance of the tumor hand in hand with chemotherapy in order to improve our treatment response? And so this led our lab to start investigating the STING pathway. So this diagram on the left is just showing what the STING pathway does in a tumor cell. And what was very attractive about this is that unlike a lot of other immunotherapies that target T cells and the adaptive immune system, the STING pathway and drugs that target this pathway are really targeting the innate immune response and trying to get at some of those immunosuppressive macrophages. So what the STING pathway does is it recognizes abnormal DNA. So DNA is normally supposed to live in the nucleus of your cell. It's not supposed to hang out in the cytoplasm. But when a cell gets damaged, when it gets an infection from a virus or a bacteria, or when you have cancer, you get abnormal leakage of DNA into your cytoplasm, and the cGAS STING pathway is responsible for detecting that and alerting the immune system, hey, there's an abnormal cell here, you need to come and clear it away. So cGAS binds double-stranded DNA, it produces cyclic GAMP, which activates STING, and then activates all these transcriptional programs that activate pro-inflammatory chemokines and cytokines and type 1 interferons. It improves MHC1 expression on antigen-presenting cells, and it promotes autophagy and cell death pathways, all things that we want to happen in an osteosarcoma tumor. This diagram over here is just looking at human osteosarcoma samples that are taken from the target database and looking just at baseline gene expression in osteosarcoma tumors. And we do see that there is gene expression of components of the STING pathway. I will say this with the caveat that it's still being, with the using STING agonists in the cancer field, we're still trying to figure out if it's important to have this pathway activated and active in tumor cells versus immune cells. But for our baseline going into this question, we do see that this pathway is being expressed in osteosarcoma tumors. And then Dr. Ladle showed this before, but this is just proof of concept from the dog clinical trial that's been run out of Dr. Ladle's lab for the last few years. So in this trial, we've enrolled canine patients with osteosarcoma, and we have treated them with intratumoral injections of 80 US 100, which is our STING agonist compound. And if I go back really quick, 80 US 100 mimics the cyclic GAMPs, so it directly activates STING and directly activates those transcriptional programs independent of the double-stranded DNA in the cytoplasm. And when we look, when we give these dogs intratumoral STING and we take their tumors out by amputating their tumors 2 weeks later, if we look under the microscope again at the sites that are treated with STING versus the sites that are not treated with STING, we see a lot more brown cells, which is indicating a lot more immune cells that have come into the tumor microenvironment now that have been recruited there by the STING agonist. And so it's hard to study what's going on and what's bringing all those cells into the microenvironment in the dogs, and so we brought this back to our mouse models to try and understand the mechanisms a little bit better. And we've been working with 2 different mouse models of osteosarcoma, so the K7M2 model and the F420. The K7M2 is a BALB-C and the F420 is a black 6 mouse. And the important thing is that these mice have competent and intact immune systems so that we can study the immune response. So if we look at what, when we give these tumor cells in a dish, if we just give them some STING agonists, what happens? We can see that they appropriately activate pro-inflammatory gene transcription programs and have induction of type 1 interferons. Importantly, these peak at about 4 hours after drug administration, and it goes away by 24 hours. So this response is pretty rapid in onset, and it goes away pretty quickly. And then again, if we have, again, in our mice, if we challenge mice with osteosarcoma tumors and then give them intratumoral STING, we're able to see 6 hours after drug administration, we're able to see a peak in interferon beta production, so that type 1 interferon production, and again, it kind of tapers off over the next few days. If we look for using the Luminex assay, looking at other if we look at other chemokines and cytokines that are being induced in response to STING agonist, we see some canonical expected pro-inflammatory cytokines and chemokines, so CXCL10, CXCL9, CCL5, but we also see some other unexpected and unanticipated cytokine and chemokine production, as well as some ones that are more canonically thought of to be pro-tumorigenic, so VEGF and CXCL2. We're still working out the significance of all of this data, but we are seeing induction of a robust immune response in response to STING. And so getting back to the question of, can we use this window wherein we're creating a more inflamed microenvironment in these osteosarcoma tumors? Are we able to manipulate this window a little bit better with our chemotherapy to improve an anti-tumor response? So going back to our mouse model, just showing you what we do for our experimental setup. So we challenge these mice with tumors. We treat them with 2 cycles of therapy, and then we harvest their tumors to analyze them. Our treatment groups, we have our controls, so our mice that are just getting treatment with the sting, our mice that are just getting carboplatin, and then our dual-treated mice that get a dose of intratumoral sting, and then 24 hours later we give them a dose of systemic carboplatin. We chose carboplatin because carboplatin is standard of care chemotherapy for dogs, and this project really grew out of our dog clinical trial initially. But notably, the platinum-based drug, specifically cisplatin, is used in MAP as part of the upfront chemotherapy, so there are correlates in humans there as well. And so getting to the data that was exciting to us and why we've been doing this, if we look at mice that are treated with our combination therapy, so that's those red bars. For those of you that haven't seen these curves before, this is a survival curve. So lines at the top mean that the mice are alive, and then as we go down, it means that the mice are dying off. But in these dual-treated mice, in these red bars, what we're seeing is that in both groups, up to about 30 to 40% of the mice will achieve complete tumor regression and long-term survival after 2 cycles of therapy. We occasionally have a mouse that's treated just with sting that survives, but for the most part, the other mice all eventually die of their disease. If we repeat this experiment in mice that are deficient in lymphocytes, so these RAG1 knockout mice, they don't have any T cells or B cells, even though we think of this drug as activating the innate immune system, the treatment response that we're seeing is still dependent on lymphocytes. So if we get rid of those lymphocytes, none of the mice survive and none of the tumors demonstrate any difference in growth compared to all of the control tumors. So this response is still lymphocyte dependent. And then if we look by flow cytometry, so meaning if we take these tumors out and we digest the tumors and we take out all the immune cells and we look at what types of immune cells are there, what we can see is that in the groups that are treated with STING agonists, so blue is STING alone and red is our dual treatment group, 24 hours after they have drug administration, they're having a significant decrease in the tumor-associated macrophages that are in the microenvironment of these tumors. And specifically, the 206 positive immunosuppressive macrophages are being driven out or changed in some way 24 hours after treatment. 7 days later, the population reappears. So it's not a sustained loss of these immunosuppressive macrophages that we're seeing. But importantly, at 7 days, what we do see is a sustained, small but sustained and significant increase in the CD4 positive and CD8 positive T cell population. So again, the T cells are the cells that we want to see there. We want to see them present in the tumor to help get rid of those tumor cells. And specifically at 7 days, if we look at the effector function of those CD4 positive and CD8 positive T cells, we can see an increase in the effector T cell populations that's in the microenvironment of these tumors at 7 days. There's a couple other alterations that we are seeing in the cells as well. So specifically, the purple is showing the NK cells. So there's a significant increase in NK cells that we're seeing in our dual-treated group. That's present at 24 hours as well as 7 days. And then, interestingly, the B cell population at 7, it's hard to see on this graph, but the B cell population actually decreases in the tumor in the STING-treated groups. And so we're still trying to understand the significance of those findings. So in conclusion, what do I think is happening here? So what we think is happening is we have this immune-suppressed cold tumor that has a lot of immunosuppressive macrophages. We give our STING agonist directly into the tumor, and we're able to get rid of all of those suppressive myeloid cells, and that happens pretty quickly. But that allows a window wherein these activated effector immune cells are able to come into the tumor and stay there for at least up to 7 days at this point from what we've seen. And then in conjunction with carboplatin, potentially other chemotherapy agents, the immune system and the chemotherapy are able to work together to lead to an improved overall survival for these mice. And so this work has been super fun, but it's mostly just left us with a lot of questions and a lot more routes that we need to understand. So we see improved overall survival, but is this really specific to carboplatin? We want to understand, obviously, how this is going to work within the context of standard of care chemotherapy, MAP chemotherapy for human osteosarcoma. And then this is a common theme for today, is what's the difference between responder tumors and non-responder tumors, and how can we learn from non-responder tumors to optimize treatment? We see that we're able to create a more inflammatory immune microenvironment, but we need to understand better the role of the innate immune system versus the adaptive immune system in this response. And I think for me, one of the most important questions is, sure, this is great. We can make MAP a little bit better. But if we're really able to get T cells into these tumors and we're really able to get the immune system to better recognize these tumors, could we create some sort of immune memory that is then going to be able to prevent relapse, that's going to be able to prevent metastatic spread of these tumors? And I think if I were to think about my pie in the sky goal, that would be the most amazing thing that we could achieve with this type of treatment. And then again, we've seen that this response is lymphocyte dependent. Are there ways that we can optimize those lymphocytes a little bit more in combination with immune checkpoint inhibitors? So these are just some of the things that we're continuing to think about with this project. Okay. All right, so with this, I'll take questions. And I just want to thank everyone in the lab that has helped to make this possible, and especially our canine patients and our human osteosarcoma patients that inspire us every day. So thank you.
I just wanted to say it's a great talk. I was just wondering, because you kind of arrive at this murine model from histology that you had from the dog study, do you also have histology from the murine model, and is it similar in terms of that invasion?
It is similar. We have about 70 samples with lots of IHC to do, so it's just taking some time, but it's actively being done right now. We just don't have quantitative data from it just yet. So, but it is similar.
Great work. I hate to be telling you about some old Hopkins data, but way back before checkpoints, Drew Pardole published a very nice experiment where he was trying to enhance tumor vaccines. And the best way he found to enhance them was with GM-CSF. I see that popped up on your list of cytokines.
Yep. Something that we're definitely thinking about. I still don't totally understand what the role of GM-CSF is in this response. GM-CSF definitely, when it's given sort of acutely, like a big bolus of GM-CSF, is helpful in the vaccine setting, but there is some data that also shows that sort of like a longer-term, low-level chronic GM-CSF could have the opposite effect and be more pro-tumorigenic. So it's a little bit of both, still trying to figure this out. Yes. Yeah, I know that, yes. With Liz Jaffe as well, yeah.
Erin, over here.
Oh, hey.
Yeah, nice talk, and it's a really interesting, evolving story. You talked at the beginning about the K7M2, which is a metastatic model, and at the end you said, really I'd love to be able to impact metastases because that's where patients are most likely going to be dying from. Have you had a chance to work with the K7M2 model and any results with that with metastatic disease with these kind of experiments?
So we've been focusing, it's a great question. We've been focusing on the primary tumors so far. I think that the metastatic niche and the primary tumor niche are very, very different. And so for now, we've just been focusing on the primary tumor. We see similar survival results and maybe even a little bit better survival response in the K7M2s, which potentially makes sense given some differences in the immune system for both models. The K7M2 is a little bit harder. We don't have as many tools. Like for instance, the RAG knockouts are in the Black 6, but not necessarily in the K7M2. So we don't have as many tools just yet to be able to study it as well as we have in the F420.
It would seem at some level that the minimal disease, going after metastatic disease when it was at a stage of minimal disease, would be more amenable to the immune destruction because you're not trying to get rid of a big bulky tumor, you're just trying to clean up cells. So it could be, if there's a way to study it more precisely in the K7M2 with the Mets, that could be very interesting.
Yeah, I agree.
Hey, Erin, that was awesome work. I had a couple maybe very naive questions. So my first is there any utility of repeat dosing of this STING agonist? Like, does that improve your durability of sort of keeping the immunosuppressive cells out and the immunogenic cells in? Have you played around with that at all?
The most I could say is that if we give 1 cycle, we don't see as much of a response. If we give 2 cycles, we do start to see more survivors, but we haven't gone as far to give more than that. We are going to do those experiments, but we just don't have that data yet.
And a cycle is like 1 dose before the cisplatin.
Yeah, so we give 1 dose of Sting, and then 24 hours later, or carboplatin, 24 hours later carboplatin, and then about 10 days later, after the mice have had some time to recover, we give cycle 2.
Okay. And then my other question is this, do you think, specific to osteosarcoma in terms of the effects that you would expect, or is this something that you could look at in other kind of cold pediatric sarcomas?
So I think the great thing about this is that we could look at it in other tumors. We haven't yet, but it's on the horizons for what we would like to do in the future. But yeah, I mean, this pathway is certainly not limited to osteosarcoma. You know, immune cold sarcomas is sort of across the board, and so I think it could have broad applicability.
That's great. Thank you.
Thank you.
There's one more question over here.
Just a quick question. Knowing that people are starting to study tumor-infiltrating lymphocytes as actual therapy, do you think it would be possible to do this, because surgery is such a huge part of osteosarcoma therapy, in the neoadjuvant setting, and then try to ex vivo expand tumor-infiltrating lymphocytes in a patient?
That would be amazing. I think about that a lot as far as, you know, if we're ever fortunate enough to be able to bring this to patients, what would be the most rational way to do this in the clinical setting? And I think that's where my hope that there's some immune memory that we're able to generate from this comes from, because I think Dr. Ladle alluded to before, most patients will respond to MAP and achieve some degree of remission, but what really, you know, what really harms people in the long run is the metastasis and the relapse. And so I think if there was maybe a way that we could give this with upfront surgery to stimulate more of an immune response and an immune memory to prevent relapse, I think that would be amazing. Ex vivo expansion of TIL sounds fantastic for that, but yeah, that would be great. We have not looked at CD47 specifically. They do, yeah.
Question over here. So I was really interested in how you're making such like a really hot tumor microenvironment, but it seems like you're not getting any abscopal effect on the tumor. So, I mean, why do you think that is, and what do you think you need to do to really get a robust abscopal effect?
Do you mean that we don't have as a robust abscopal effect because the T cell numbers are not as high, or?
Yeah, I was kind of inferring, you know, outside of the tumor injection or treatment site, you don't see a lot of infiltration of T cells.
Yeah, to be honest, I'm not quite sure. To be honest, I've been surprised that the number of T cells, at least that we're seeing by flow, is not higher. I mean, it's significant, but it's not like, you know, it's not like we're going from 1% to like 35% T cells in the microenvironment, but we are clearly seeing an effect. I don't know if it's just, I don't know if it's more of a reflection at the time points that we've looked at so far, and so we are going to be repeating, looking at some other time points to see if maybe at other times we're seeing more infiltration. I don't know if I have a good answer for that. It's a good question. Okay, thank you.